All right, good afternoon, everyone. We're about to begin. Please confirm that you're hearing me online.
We're hearing you.
Yes, we're hearing you.
Good afternoon.
Okay,
Yes,
good
we're hearing you.
afternoon. Good afternoon. So we've met, so I'll just go right into it.
Sometimes, yes, get the help, read the book, get in the know. Thank you so much, Dr. My sister's out there.
Denise, can you
That was
mute?
Dr. Ivan Thomas, MD.
Please mute. All right. So as I said, we've met, so I'll just get right into it. And today we'll talk about outbreak investigation. We'll do some definitions, speak about types of epidemics, look at the epidemic curve, look at goals of an outbreak investigation, 10 steps of an outbreak investigation, management of an outbreak, look at the outbreak management team, and we touch a little on the international health regulations. So there's a video that I want to show that I think summarizes most of what we're going to talk about, and it will make the information that I present after much easier. I'm just going to come out of the presentation. Oh, maybe I stop share this now. I forgot what Sebastian said. And I put this on. Nope. Try and remember what Sebastian just told me. This. Okay. All right, I'm going to play this. Hopefully you'll hear it too.
Welcome to this video on outbreak investigation. We'll take a look at what an outbreak is, how it's detected, investigated, and controlled. First of all, what is an outbreak? Basically, an outbreak is when there are more cases of illness than what's normally expected in a population in a given area and at a given time. The terms epidemic and outbreak are sometimes used interchangeably. How do we detect outbreaks? Well, there are several different ways. The existence of an outbreak may be known through a variety of surveillance methods. These include passive surveillance, which is monitoring routinely collected health data; active surveillance, when health information is actively sought out; sentinel surveillance, where selected groups or institutions provide health data; syndromic surveillance, which is the monitoring of illness syndromes; or through a variety of other sources of information, including the social media, news, or even hearsay. Once a decision is taken to investigate the outbreak, it goes through a few systematic steps. The number of steps, order, and content can vary, and several steps can be done at the same time. But in essence, an outbreak investigation consists of confirming whether there is an outbreak, describing it, determining the cause of the outbreak, and then implementing control measures so that it doesn't spread further or happen again. Let's take a look at the steps in a bit more detail. Confirming that there is an outbreak is the first step of an outbreak investigation. To determine whether there are more cases of illness than what's expected, we need to know the baseline level of illness in that population for that given time. Then we can compare it with the level of illness we're seeing to see whether there is an increase. However, it's important to note that even if there are more cases than expected, other causes of this apparent increase, such as a sudden increase of testing, a lab or diagnostic error, or a sudden increase in population, needs to be ruled out. To work out what's causing the outbreak and to help decide on the best control method, it's necessary to verify the diagnosis. This is usually done by reviewing the clinical and laboratory findings. Now at this stage, there could already be immediate actions that can be taken to control the outbreak, especially if the source and mode of transmission is known. To proceed with the outbreak investigation, it may be necessary to get a team together. The size of the team will depend on the nature of the outbreak. Once the outbreak has been confirmed, the next step is to describe the outbreak. Describing the outbreak provides an insight into who's affected, where the illness occurs, and other characteristics of the outbreak. Let's take a closer look. To describe the outbreak, investigators need to figure out who should be considered a case, determine whether all the cases have been found, and then describe the cases. To figure out who should be considered as a case, there needs to be a case definition. This sets out the criteria which need to be met in order to classify a person as a case. Generally, there are criteria for time, place, person, clinical and laboratory features that must be satisfied before a person can be classified as a case. Once there is a case definition, cases are looked for in a systematic way and information about the cases is recorded. This is usually done by using questionnaires and summarized by time, person, and place. Let's have a look at each one of them, because each of these provide useful insight into the outbreak. By describing the occurrence of cases over time, investigators can look at how the disease has developed over time. This is typically displayed in a graph that shows the number of cases in the y-axis and the time on the x-axis. This type of graph is known as an epidemic curve. There are two common patterns of an epidemic curve. The first is a point source outbreak. This happens when the outbreak is from a point source. For example, if there's an outbreak of gastroenteritis after eating a contaminated dish served at a restaurant. The typical pattern of this is a sharp rise in cases followed by a rapid decline. The other one is a propagated outbreak. This pattern is common in outbreaks where the infection is passed from person to person and the first wave of infections is a source for the next wave. The typical pattern of this curve is a series of progressive peaks of illness. The other descriptor is place. This can provide information on the geographical spread of illness and identify if there are any clusters. Modern mapping tools and geographic information systems technology have become important tools in mapping and tracking outbreaks. Describing people who are affected by the outbreak, for example by age, sex, occupation, and ethnicity, can provide useful insights into the disease. It allows investigators to figure out who is at further risk. And that's a look at the second step of outbreak investigation, which is how to describe an outbreak. Figuring out what caused the outbreak is the next part of the outbreak investigation. From the information that is available from the steps before, investigators might have an explanation for the likely cause of the outbreak. This is also known as a hypothesis. Now, if the pathogen that's the cause of the outbreak is already known, then it can provide useful information to guide investigators to the likely source and mode of transmission. For example, in an outbreak caused by cholera, investigators would look at contaminated water as the potential source of the outbreak. If it's a salmonella outbreak, it's likely due to contaminated eggs or meat products. If, however, it's not very clear, investigators need to test and confirm the hypothesis that was developed. This is usually done with an analytical epidemiological study. The two most commonly used types of analytical studies in outbreak investigations are cohort studies and case control studies. These studies can determine how likely it is that a certain factor is the cause of an outbreak. In addition to the analytical epidemiological studies, an environmental investigation can also help confirm the hypothesis. For example, in a foodborne outbreak, the environmental investigation could identify factors like contaminated eggs, improper food storage, or poor hygiene standards that may have contributed to or caused the outbreak. Laboratories are very useful as they can provide microbiological information to confirm the hypothesis. And that concludes our third step of determining what could have caused the outbreak. Now let's discuss the primary goal of investigating an outbreak: control. Control can happen at any stage of the outbreak investigation and can be targeted at any step of the transmission pathways between the agent, host, and the environment. Control measures include behavioral interventions like using mosquito repellents to prevent against mosquito-borne diseases, vaccination like giving measles vaccine during a measles outbreak, medication like ivermectin for scabies outbreaks, environmental measures like insecticide spraying during a malaria outbreak or improving water quality during a cholera outbreak. Infection control measures like isolating infectious cases, wearing appropriate personal protective equipment, and disinfection of medical equipment to restrict further spread of the infection. Providing targeted and appropriate health education will ensure that those who are sick will know what to do to stop spreading the disease, and those who are not sick will know what to do to prevent getting sick. After control measures are implemented, there should be active surveillance to monitor the outbreak to make sure that the control measures are working. That was a quick look at the different ways that an outbreak can be controlled. Now let's talk about communication. This is an important aspect of managing any outbreak, large or small. Communication is about making sure that accurate, timely information gets to the right people at the right time. This can be those who are internal to the organization or those who are external to the organization, like other organizations and the public. Communicating to the public is important, especially to those who are affected by the outbreak. It allows them to adopt protective behaviors, helps with disease surveillance, and reduces anxiety, confusion, and misinformation. The media can be a useful partner in outbreak communication. Sharing information about the outbreak using online forums or scientific journals, and describing what measures were taken that were effective and what lessons were learned can help others manage future outbreaks. Finally, once the investigators are satisfied that the outbreak is under control, it must be declared over. For infectious diseases, this is usually when there are no cases after 2 incubation periods have passed. And that's a quick look at infectious disease outbreaks. We had a look at what they are, how they're detected, and steps involved in an outbreak investigation, including ways in which outbreaks are controlled.
Right, so you have an overview about outbreak investigation, and I will highlight some of the things there and update on others. So the steps given in terms of outbreak investigation, we talk about the 10 steps in outbreak investigation. So all the steps weren't listed, but I will go into it in a little bit more detail. But now you have that background, I think it will make it easier for you to follow all that I will say. They've given the definition: an outbreak or an epidemic is the occurrence of a disease that's clearly in excess of what is normally expected. And when we talk about outbreak or epidemic, it's the same thing. They mean the same thing, but sometimes it is said that when you say epidemic, then it gives a greater sense of panic. So you may want to use the more euphemistic term to say outbreak. Not sure how you feel about that. I mean, outbreak sounds serious to me. You know, epidemic, people might not know what that means, so it won't cause them to panic. But outbreak, you know, that sounds very serious, but you can use the words interchangeably. Now, if you don't have any case of the disease, and someday you have a single case, then that would constitute an outbreak or an epidemic. And the rationale is based on the definition. You would
Just a
not
quick thing. Good
normally
evening.
expect any case at all. So 0 cases is what you expect. So when you have 1 case,
Sorry, Doc.
then
Hi, Doc. Sorry, quick thing. Hello?
yes, okay, yes, go ahead.
Oh, it just sorry to cut you. I just wanted to ask if there's like a fan blowing in the mic
No,
or
I'm asking if
something.
Cheryl can close her mic, please.
Think somebody's mic on.
Okay, it's closed. Thank you.
Okay. Sorry, Doc. Continue.
That's better. Yeah. Okay. All right, great. We have that sorted. So, as I said, 1 case may constitute an epidemic because if you expect 0 cases, and then 1 case would be more than what's normally expected. Now, I know you may say Jamaica has several cases of malaria each year. Maybe between 3 and 5 each year. But those are not locally transmitted cases. So in this case, we're talking about locally transmitted cases. So if we have an imported case, it's contained, then we don't expect any case of malaria. But if we have an imported case, then we're not going to say we have an outbreak. If we have a case, though, we don't expect any case, but if we have a case, we don't know the cause. The person is living here all their lives and then no travel history at all, not an imported case. And all of a sudden, this case, when we do the test, we have a case of measles or malaria that we would expect no case, then we're talking about autochthonous transmission, and then we would say we have an outbreak. All right. Not sure if they can hear you, Solo. Can project?
Okay, so just looking back at the initial definition, what is normally expected? Is there, or is there we do not expect? We are doing not expect because if it's a case where we, for example, we expect, all right, if we're gonna have, for example, the flu virus, right? The flu. We expect, okay, we expect say about 20 persons in this region to have it. All right, so if it goes above that, we say we have an outbreak or an epidemic. So I'm saying, no, because I'm thinking, no, should we be expecting, anticipating, or?
Like malaria and measles and those things?
Yes.
Okay, well, based on what happens each year, we expect to get imported, put it this way, we expect to get imported cases of malaria. We expect to get 3 to 7 each year, usually from malaria endemic areas. What we don't expect is to have local transmission of malaria. So if we have a case where we don't know the source, the person didn't travel, then we can say we have an outbreak, because we don't expect that. All right, so we defined an outbreak or an epidemic, and it's usually limited to a localized area, like a village, a town, an institution. And when we say cluster, it's an aggregation of cases. So several cases in one particular area, doesn't matter what you expect or not. Several cases in one area. So in the COVID pandemic, we had clusters of cases. We had cluster in the BPO. We had clusters in nursing homes, in infirmaries. We had clusters. We had workplace clusters. So several cases concentrated in one area. But then when we talk about pandemic, and it's usually the WHO who declares this, it's an epidemic or an outbreak that spreads over a larger area. So several countries or continents being affected, and it's usually affecting a substantial proportion of the population. All right. So an outbreak is a public health emergency. When we have an outbreak, it's all hands on deck, and we set about to investigate and to control it, because it can have serious implications for the people affected in terms of their health status, but also for the wider community, for the country in terms of the economy and so on. We lived through that with COVID. An epidemic occurs when the agent or whatever is causing it and the susceptible host, that's usually the people who contract it, are present in adequate numbers, and the agent can be transferred from the source to the people who are susceptible. So if we have an increase in the amount or the virulence of the agent, then we can have an outbreak. And we can go back to COVID, we had an immunologically naive population. Nobody here had ever had COVID before. And then you had imported cases. So, it started in China, then started spreading, and then we had people coming to Jamaica with COVID. So the agent came. We are susceptible. We have no immunity at all. And definitely the vaccine wasn't around at the time. And so increased amount of the agent, we have a susceptible population, we had spread. So that example can be used for the second point too. Recent introduction of the agent into a new setting, enhanced mode of transmission. So more susceptible persons are exposed. So the mode of transmission, not sure if this is an appropriate example, but the virus mutates and gets to be outside of just being causing illness when it's in the lower respiratory tract, then it can cause illness even in the upper respiratory tract. Then, of course, you can have more persons getting the illness or the disease. Changing the susceptibility of the host response, like if there is some immunocompromised state, if the agent gets into an area where you have persons who have a lower immune system, like nursing home and so on, of course, you're gonna have outbreak there. And factors that increase host exposure or involve introduction through new portals. So increased host exposure, of course, when we have an infection that's transmitted from one person to the other, then in crowded situation, whether it is at a party or at an event, then you can have an outbreak coming out of that kind of situation. So 4 goals of an outbreak investigation: case management. Let me just try and move this off the screen a little. One moment. Case management, containment of the infection, searching for the new cases, and protect persons who are susceptible but not yet infected. And we're going to look at them one by one. All right. For case management, if a person has the disease, then we want to prevent severe disease and definitely to prevent serious morbidity or prevent mortality. So we're looking at how we're going to treat them. We're looking at hospital isolation areas, looking at getting more of the medication, having those things available. For containment of the infection, we have to break the chain of transmission using infection prevention control mechanisms, or if it is, say, a vector-borne illness like dengue, we try to do fogging, educate persons about destroying mosquito breeding sites so that it doesn't continue to propagate. Or we have to isolate the persons who are ill from persons who are not ill. We did that with COVID. Of course, if we have a malaria case, they're going to have to be under some impregnated mosquito net to prevent transmission to other persons who are susceptible. To monitor the epidemic, we have to look for any new case and to disseminate case definition so that people know what would constitute an actual case. And we protect persons who are susceptible. So we try to find out who is this illness affecting the most. If it is the elderly, then we have to do elderly shielding. I think in COVID, Jamaica attempted some of that. So elderly persons, well, they were prioritized for vaccination. They were told they can't leave the house, while the younger, more I don't know, persons with better immune systems were allowed to be out and about, but you protect those who are more susceptible. All right. We're going to move to types of outbreak, and I've said, you know, if you have a question or comment, just open your mic and say it, or in here, just go ahead and interrupt and ask the question. So we divide the outbreaks into common source outbreaks or propagated, but can also be mixed. And for common source outbreak, you can have point source, intermittent, or continuous. All right, so we're going to look at each of them. Remember, common source, propagated, or mixture. For the common source, you have a group of persons that are exposed to the agent from the same source. Not sure if to go in, I will give examples of that a little later. And for propagated, it's transmission from one person to the other. So it continues to have secondary cases, tertiary cases, and so on. Usually direct person-to-person contact. So if we're looking at common source outbreak, you can have a common source from a one source. You can have point source, intermittent, or continuous. And we will look at those one by one, but to say for point source, the exposure period is relatively brief, just a single source, everybody is infected at the same time. And all the cases tend to occur within one incubation period, and that's it.
Church picnic.
Church picnic and Chernobyl, yeah. All right. For the exposure period can be brief or extended over days or longer, and it can be intermittent or continuous. Let's look at what the epidemic curve looks like and what the examples are. All right.
Sorry, one second again.
Need to know.
Redman, mic open.
Oh, sorry.
All right. May seem disjointed because I couldn't find where in the presentation to put this, but you need to know about epidemiological week, so I thought just put it right here. Sorry about that. It just came out of nowhere because we're talking about types of outbreak. But because we're going to look at different epidemic curves and what the types of outbreak look like on an epidemic curve, we have to introduce the epidemiological week. So the epidemiological week is a standardized way of counting the weeks in a year, 52 weeks in a year, but there's a standardized way for counting them so that we can, when we talk about week 1 of this year, it's the same thing that the US or Barbados is saying when we say epidemiological week or epi week 1. It's the same week that we're talking about. The first epi week of the year ends on the first Saturday of January, as long as it falls at least 4 days into the month. So this is up on the top right, you have the calendar for January of 2025. So it's there. We have 4 days in January. That can be in the first week. So that will be epi week 1. But if January started on a Thursday, then it wouldn't be epi week 1. So you can see how if we don't have the weeks numbered, then in a standardized way, then we can say it would be, some persons say it's the first week, even if it starts on a Saturday, and call it week 1. When you say, oh, it's not really a full week, so we're not going to count that week, we're going to count the first full week. So we just try to use a standardized way, and it's understood in epidemiology. When you say epi week 1 will be the first week of January, if that week has 4 days, at least 4 days in January.
Excuse me, miss. Just a question here. Yes, I'm asking a question. All right. So
ahead.
come January 2026, where the month starts on a Thursday. Does it mean that we're going to have 53 weeks, epi weeks for the previous year? Or we don't
Yes.
report on that week any at all? You're going to have 53 weeks.
Yes, and that's okay. We'll have 53
Okay.
weeks. I have to look on the calendar for this year.
It starts on Thursday. The first is on a Thursday.
Okay, so that week will go toward 2025. It won't count as epi week 1. Epi week 1 will start on the Sunday the 4th of January in 2026. That will be epi week 1, even though we have some days in January or 2026, those will go toward the last epi week in 2025, and we call it 53. It goes to 53. That is okay. So some years we have 53 weeks, and some we have 52 weeks. But each epi week begins on a Sunday and ends on a Saturday, apart from, but it starts on a Sunday, ends on a Saturday. So epi week 1 for this year has some days from December of last year.
Right,
Yeah.
okay.
Okay. And so even for this epidemic curve that you see and I got it from, you can see it up our WHO website with the number of cases of COVID-19. They have week 1, that's in 2023, week 1 to 48. It would be the epi week that they're talking about when they say week 1 and so on. All right, so that's epi week. The epidemic curve, and you saw it in the video, a graph of the occurrence of cases over time, and you have the number of cases on the y-axis and the date, whether it is days, weeks, or months on the horizontal axis. The time is shown on the horizontal axis, and this is the sample epidemic curve showing confirmed COVID-19 cases in Jamaica 2023 to a part of 2025. And you see the time on the horizontal axis and the number of confirmed cases on the vertical axis. So that would be an epidemic curve. All right, now we can look at how the epidemic curve appears for different types of outbreak. Just a reminder though about how we determine an outbreak. It's above what we would normally, the cases are above what we would normally expect. So we normally expect it to be the purple line, the mean, the average is what you would normally expect. So looking at years of data from 2007 to 2022, years of data. When we look at the number of cases in January 2007, January 2008, January 2009, up to 2022, on average, what we would usually see, that's what we see in purple. Now, what we see in yellow is the alert threshold. That would be the mean plus 1.645 times the standard deviation. So we expect 90% of the time that the cases should fall below that line, 90% of the time. So if it is going above that line, then we know something is definitely wrong. We're 90% sure that something is wrong, put people on alert for influenza outbreak, send out a press release, okay, we're on alert for that. If the number of cases of dengue though goes above the mean plus 2 times the standard deviation, then we're 95% sure that this is not normal. It's above that, we're 95% sure we declare an outbreak. All right, so this is what you're seeing, that starting June of 2023, the number of cases of, the monthly number of cases of dengue went above the epidemic threshold. Yes, we did have an outbreak and lasted into 2024. And then after that, from August 2024, the cases went back to what we would normally expect. All right. So the epidemic curve is a basic tool of an outbreak investigation, helps to distinguish between an epidemic and endemic level disease, and it shows the magnitude of the epidemic. If we look at the shape of it, it can give, and based on the pattern, it can let us know the pattern of spread, whether it is common source or propagated. It indicates the progress of an epidemic. So for the epidemic curve I showed in August, we saw it's still increasing September, October. If we see it's still there, then we can say it's still on the upswing. And then in December, when we look back at the cases, December 2023, we can say, okay, seems like cases are on the decline. So we use it to monitor the epidemic. And if the incubation period is known, then we can kind of figure out when persons were exposed to the illness.
Yeah, doctor?
No.
Hello, doctor?
Yes, Miss Doctor.
Yes, good afternoon. All right, so relating to your previous chart on dengue, I noticed where the epidemic threshold actually fluctuates. What is it that causes it to fluctuate like that?
Okay. The epidemic threshold, the alert threshold, the mean fluctuates. Dengue is seasonal. And what we're looking at for each month is the number of cases that we've seen for that month from 2007 to 2022. So we have the data from 2007 to 2022 and the number of January cases in 2007, 2008, in 2010, 2015, and we get the average of average. So on average in January, we would see, I don't know if that is 90 cases or so, but on average in October, when we look at the data from 2007 to 2022, we would usually see, let me see, the mean is about 110 cases. So it's based on the data, and because it's seasonal, then it fluctuates from month to month, but we average what we would usually see in each month for over several years.
I see. Thank you.
Okay.
Yes, it is. Thanks.
All right. I think I was here.
Just to be clear, Doctor, we would add up all the cases for those months for each year to get the average of.
For a specific month.
Right.
Yeah.
So all of October's information from 2007 all the way up to 2022 for 2023?
Yes, yes.
I don't know what comes in 2023.
No, because we wouldn't put 2023 here.
So to get the mean is all the way up to 2022.
Right, because we have complete data up to 2022. And then when we go to 2026, we're going to throw in to the mix 2025 data. And so the mean, the alert and epidemic threshold will change a bit, but because it's seasonal, we still would probably expect it to be higher around October, November. And we do that for dengue, for influenza, and the syndromes as well. We plot either by month, or if we have more granular data, by epi week. So on average, how many cases of fever and respiratory symptoms would you expect in epi week 20? And we get the alert and epidemic threshold. So very cautious about saying that the epidemic curve is usually a histogram, because when you Google it, and even in this presentation, many of them aren't. So what I will say is, if the epidemic curve is represented as a histogram, that means you have no space between the bars, then the area below the curve will be proportional to the number of cases. But many times you have a bar chart, case in point, and you're going to see many more bar charts, right?
Excuse me, miss.
Yes.
Just a comment though. Back to the curve. And all I know from my parish, when we're doing the reporting on the ADs index, yes, that one. When you're reporting on the ADs index monthly, we do the same thing, but we don't use like threshold and means any at all. But saying like we have 2023, 2024, and 2025, there's a comparison of 3 years. And then come next year, 2023 will fall off, and we have 2024, 2025, and 2026 as we go along. We do something similar.
Okay, so you're comparing the present year with the data from the previous year?
Each month as well. The month and the year is the same thing. And this curve that I'm seeing here. Comparing the ADs index, the ADs index for each month.
Index. Okay. So that's okay, but not like for an outbreak. For an outbreak?
No, not for an outbreak.
It
just tells us it tells us, for instance, because again, you're talking about seasons. It's seasonal. So when you're going to have a high ADs index as compared to a low ADs index, depending on the month of each year.
Okay.
Yes.
Okay, so if you have several years of data, you can average what the index is, say for October or November, and then you can say on average you expect the index to be X or Y. Yeah.
And then if it goes over what you expect, then you can say, okay, something is happening here that wasn't happening the years before.
Right.
Quick question, sorry. So Nashan, so you guys use that information to plan your strategies around how the vector team or the larvicidal team goes? Like, what you use the data to?
All right. Depending on what's happening for the month, then the intervention might be tweaked depending on what was found during that month for the next month coming. Because if you see that you're right to go on over what we're used to, that means something's happening out there, or maybe we're not doing something that we're supposed to be doing. So then we investigate, plus have intervention as well.
Okay. All right, thanks for that. So, all right, something has fallen off. So for the x-axis, it's time, and we include the pre-outbreak time as well on the x-axis so that we can see what the baseline levels are. I'll just show you. So some months before the outbreak, it is represented here so we can see what it was before we went into the outbreak. And what's dropping off here under the x-axis is to use the appropriate time interval, whether you're going to use weeks, months, or if you use the exact date, that would be the days.
Use the
Appropriate time interval. That's the other point that's hidden on the x-axis equals time. For the y-axis, usually one square represents one case, but that's really if you're going to be plotting it by hand, which don't usually do, but whoever's teaching you biostats, they allow you to do the calculation, use your head to do it, and then tell you you're not going to do this in real life. All right. You give the epi curve an appropriate title and label the axes as appropriate. So interpreting it now, the shape of the curve is determined by the pattern where a common source propagated and the time period over which people are exposed. You have the minimum average and the maximum incubation period, and you will see it on the curves coming up. For common source epidemic curve, you're going to see for point source, continuous and intermittent, and the propagated source. All right, so this is a sample of the epidemic curve for a point source epidemic. All right. So persons are exposed to the same source over a relatively brief period. And somebody gave the example of, was it a banquet or
The
church picnic? So church picnic, a wedding, they're exposed to the same infectious agent, or say it's the, I don't know, it's a potato salad.
Yeah.
the potato salad, all of them exposed to it. So the epidemic curve has a steep upslope and then a more gradual downslope, and all the cases occur within one incubation period. Another example is the Chernobyl nuclear accident that was in 1986 in Ukraine. And then as more immediate effects, you have radiation sickness, you have abdominal pain, vomiting, burns, and so on. And then longer term effects, which of course would be harder to monitor, would be thyroid cancers in children because there was contaminated milk, and different types of cancers from it as well. So
like secondary attack rates. So if grandma went to the church picnic,
mhm,
got the disease,
right?
then I, who did not go to the church picnic, got it from grandma. Would it still be considered a common source or no?
Oh, you're gonna get it from grandma.
Well, do you ever have a question like that? I don't know how it is, but she carried home.
and then she come with diarrhea and then she touch
Diarrhea
here
and touch, then that would be more propagated,
Okay.
because propagated will be more from person to person. Right. Yeah. It's the persons who ate it, because it's point source, one. She brought it home. Oh, she brought home the salad and you ate some. Well, that complicate matters. No, but this is point source. But what, I'm glad you brought up that example, because nothing in real life is as clean and perfect as that. And nothing in real life is as clean and perfect as this epidemic curve that I'm showing you. So,
love to take home, you know, things.
yeah.
Yeah.
Yeah, let's stay here. We have our doggy bag, so we're gonna carry home some food, and others will get it
To the
too.
same source.
Same source, it would be the same source, but it may be a different time because they may eat it later and you see the effects later. But back to common point source, most of the cases will occur at the average incubation period. And you see the taller peaks at the average incubation period. But usually for any illness, the incubation period is given as a range, and you have the minimum incubation period. So you start seeing people, maybe those with weaker immune systems, you know, those start occurring. And then you have average incubation period, most of them, and those who would be at the maximum incubation period would be, say, those with much stronger immune system, for example, but it's usually a range. You just have steep upslope and gradual downslope, and that is it. For the common source now, but continuous, then the duration of exposure is over a more prolonged period of time. So you have a more gradual upslope and then a plateau. So people are still being exposed over a longer period of time. An example would be the cholera outbreak from contaminated water pump, where people get exposed, you have infection, but they're constantly drinking water from the same source. And so you have more cases occurring, and the period is more protracted over a longer period. And then the illness will continue until either the source is exhausted or there is some control or the source is removed. So the pump's removed, and then, you know, the cases gradually fall. Well, that's a symptom, but where is it coming from? Where they get the G from? Is it the water that they're drinking? So several people from the same source drinking this contaminated water for a prolonged period of time, then yes, one of the symptoms would be diarrhea, so GE. So you see how they upstroke, plateau, and then when it's exhausted or the source is removed, then you have the cases stopping. For the common source intermittent now, they have exposure to the causative agent, but the exposure is more sporadic, and the peaks look jagged and at different, use the same word, intermittent, you know, several, but there's a break in between that reflects the intermittent exposure. And it could be a contaminated water source, but only under certain conditions. For example, with the heavy rainfall, and I think I have a sample there, not saying 100%, but this could be, where we have contaminated water sources. When we have heavy rainfall with the leptospirosis outbreak, we saw it when we had Hurricane Beryl, an increase in the cases right after Hurricane Beryl. You know, people trying to either escape from the danger or wade in, clean up the place and get exposed to contaminated water sources. You're not drinking it in this case, it's a different mode of transmission, but due to intermittent, no, one could argue it's different places, but just as an idea, I thought the epidemic curve kind of resembled the intermittent common source intermittent. But in between, you're seeing cases because leptospirosis is endemic in Jamaica. So you would usually have some cases, even though you don't have the heavy rainfall. And then we are in a leptospirosis outbreak post-Hurricane Melissa with people reporting exposure to contaminated water sources.
For the common source intermittent, so the breaks that we're seeing with the different peaks, this would talk about different incubation periods.
So people are exposed. So it's almost like you have the several point source. So people are exposed, several people, they get infected, and then it stops. Okay, because they're exposed intermittently. And then they're again exposed, and you have another cluster, and then stops, and then they're exposed again, right? So it's like several point source. All right, so that's for common source. Then we have propagated. Propagated, the spread is usually from person to person with increasing numbers of cases with each generation. So you have a series of progressively taller peaks, one incubation period apart. So one person gets infected, and then they go home, and it spreads within the family. After one incubation period, remember, you have an average incubation period, a minimum, average, and maximum, and you have a few cases. Now, this nidus of infection now have the potential to spread because they work at different places or go to different schools. So you have one person going to school, another person going to work, and you have that spreading. So you have secondary cases at home, then you have tertiary cases, and then you have more and more persons getting infected with each generation. And we have a chart. So this one is kind of a mix where you have point source, you have the index case, and when the person goes home and spreads it within the family, that will be like a point source. One person, it spreads, and you have that cluster with the initial cluster. And then when they spread it now, you see progressively taller peaks, and the peaks can merge into one and start looking like a wave, like you saw with the COVID waves. So this is what the confirmed COVID-19 cases between March 2020 and April 2020. So that is, remember the first case was March 10, 2020. So that's very, very early in the outbreak. And so you had one case, but it's a bit complicated because you had the imported cases coming. So you had in blue, it's several imported cases in different parts of the country. But then you start having a peak, and with the eye of faith, you can see progressively larger peaks. But when you look at the bigger epidemic curve with a longer series, you realize that this just merges into one wave. But at the beginning, you can see how it could resemble the propagated pattern with the eye of faith.
I was about to say my faith is very weak, doc, because I'm not seeing it.
Oh, no.
My faith is very weak.
We need to pray for you.
Same case with COVID. So there first one lady that they said had COVID,
Yeah.
but she came on a plane.
Mhm.
There was a person they previously tested and they did not have COVID. And then they confirmed to have COVID. Would it be an imported case or whether they are contact of the confirmed case be the lady?
If they didn't have it before, but it's after exposure to her, then there would be contact of that confirmed case. Now, to Dr. Thorpe, it looks a bit complex because you don't have like one source. You had several imported cases all over, so that kind of confuses the picture. But I was trying to get something from real life rather than just using these. Maybe it didn't work, but I'm sure that there are probably some people in here with enough faith to see it. All right, 10 steps of an outbreak investigation: confirm that the outbreak exists, verify the diagnosis, make a quick assessment of the patients, relate the case in some way, formulate a hypothesis, plan and conduct a detailed epidemiological investigation, analyze the data, formulate a conclusion, put control measures in operation, and write a report. No, just to say several things can be going on at the same time, because it's not that you wait until you have everything together before you communicate, or we know it's several reports that's gonna be written maybe every single day. It's not at the end of the investigation.
Report from this course.
Huh?
We'll learn how to write the report from this course.
From this, not, I don't know, from this course, but not from this lecture.
But I'm wondering if parishes will need to do this, or this is just based on ministry level.
Parishes will report on what occurs within the parish, but ministry will collate everything and report for the country. So it's done at every level.
I'm just wondering if the parish should have to do these 10 steps, then pass it on to the region, and then the region do some things. That's what I'm thinking. Like, okay, does the MOH have to do all of these steps?
Yeah, they have to write reports. They do.
The parish does all of that.
Yes. So on CDC website, PAHO, you see 10 steps of an outbreak investigation. So at the bottom. Confirm that the outbreak exists. So you compare current disease data with earlier data and determine if what we're seeing is in excess of what we would normally see. Now, if I could skip back to the leptospirosis curve and make a point here. If you notice on this one, we don't have the alert threshold and epidemic threshold, but still, after Hurricane Melissa, based on the number of cases, we were able to see that we have an outbreak. We didn't have years and years of data to do those calculations, because usually you would have at least 5 years of data, you know, for you to say it's kind of reliable. The mean is kind of reliable. But based on what you would usually see, clearly, you know, it's more than what we usually see. So we can say we have an outbreak. Now, we may not be saying it's statistically significant because we don't have the alert and epidemic threshold, but it's clearly in excess of what we would expect. And we can say that we have an outbreak. So we compare the present data to earlier data, and we can say we have an outbreak. And we verify the diagnosis usually by looking at the clinical picture, the symptom that they're presenting with. So the leptospirosis cases, the fever, headache, the muscle aches, and the calves, and so on, weakness, jaundice, and so on. Then we say, this is probably lepto, especially since we know we had heavy rainfall. We're going to test, but these symptoms may look like dengue too. So we test for leptospirosis, we test for dengue, chickpea, Zika, and what comes back in many of them, leptospirosis. So we can say that is the diagnosis. When we make a quick assessment of the cases, so we have to have a case definition. And then when we had an outbreak, we had to do a case definition. For leptospirosis, the one we had before was kind of non-specific. So we had to make it more specific to say, if you see somebody with fever, headache, myalgia, weakness, and they have any of the complications like jaundice, kidney failure that would suggest Wheels disease as a severe leptospirosis, then we have to call it. So we have to give the case definition. What are you going to call a suspected case? If you see somebody with some of these clinical features and they also have an ELISA test, like IgM positive for leptospirosis, we're going to call it a probable case. But if we did the PCR and it's positive, then we call the case a confirmed case. So we have to say, what are we going to call suspected, probable, confirmed case for whatever illness that we're looking at, and look at the cases in terms of person, place, and time. Are they males only? Yeah, mainly for the lepto. Yeah, mainly in the current outbreak. The question is surmise that those are the ones who tend to be the farmers, who tend to be the ones out there cleaning up, clearing away the garbage, sweeping out the water and that kind of thing. Try to figure out where the exposure occur. Is there common travel history among the cases? And in terms of time, we look at the onset of illness, very important. When did they start exhibiting symptoms? That date is very important. And we have a hypothesis to say, what do we think the cause is? And what do we think the cause is based on the clinical laboratory information that we have, and that will guide the investigation. So we're doing a standardized, detailed epidemiologic investigation using standardized tools that I spoke about. If you're going to use a case investigation form, so for each case or each case that we think could be a case, then we fill out detailed information, demographic information, age, sex, where they're from, which community, and what symptoms they're exhibiting. Do they have any comorbid conditions? Do they have contacts? And then it suggests we can do case control study. Not gonna say that we do it in real life. Okay. We analyze the data, so that should be done as soon as possible. And it's a daily analysis, not, as I say, complex analysis, but how many cases we have, male, female ratio, what we report on, how many in each parish, so time, place, and person, attack rates, and I will go into how we do the calculation. Not sure if it's next or maybe it's just a little bit further down. And then we conclude based on the evidence that we have. As a part of it, we have to put control measures in place, whether it is isolation of those that are infected, quarantining those who are exposed. It could be that it's a community that's gonna be quarantined. Could be that you're doing fogging because it's a dengue outbreak. Definitely when we have imported cases of malaria, you do fogging in the area where the person is receiving care or lives. Immunization. I feel like I have this further down, so I don't have to go into detail here. Immunization for certain situations. And the report that's clear, precise, and usable, and it should include recommendations and disseminated to not just decision makers, but whereas the report wouldn't go necessarily to the public, aspects of it because it need to be communicated to the public. They need to know what is happening, where are we seeing the cases, what should we do to protect ourselves so that everybody can be involved in the solution. Which brings me to the management of an outbreak, which is the 10 steps is 10 steps to outbreak investigation. Now, the management, when we declare that the outbreak exists, then we have to inform health providers that the outbreak is occurring and help them to know how to respond in each parish, in the institution. And we need to know, are there other persons that we need to bring in on this to make them aware? The community, the media, and the communication that you have with different stakeholders will be tailored to what they need to know. Sometimes too much information can cause panic. Certainly with the COVID pandemic, we had the infodemic, we had vaccine hesitancy. You know, everybody was an expert on COVID after a while, couldn't really tell them anything. All right. All right. Oh, the thing got distorted. Was it printed distorted way too? Yeah. Oh, sorry about that. All right. They're not intended to be strike through. It was separating, there are lines that were separating the points based on the infographic that was there. So you consider the capability and capacity of the lab, and let's say luckily we had capacity to test for leptospirosis, but for certain conditions we have to send overseas. Certainly for COVID, initially we were sending the samples to CARFA in Trinidad, but by the time we had the first case, we had in-country capacity. Consider availability of medical supplies, whether it be vaccine, personal protective equipment for persons who will be dealing with the infected persons or those exposed. The healthcare workers have to be protected. Of course, it's different levels based on the pathogen that we're dealing with. You know, with the Ebola, you have hazmat thing suits, but with COVID, you have the N95 mask is enough, and with proper hand washing. So different things that you have to consider. If it's a gastroenteritis, we have to have oral rehydration salts. And if the country cannot manage, then we have to ask for help from external sources, international organizations. But certainly, when the outbreak is over, and it's usually when cases go you have 2 incubation period without any cases, then we can declare the outbreak over. You're asking me that. Somebody's asking me, was COVID ever declared over? There was a point when WHO said it's no longer a public health emergency of international concern. There was a point when WHO said that, but WHO didn't actually say outbreak is over. No, I don't believe we said that.
So they're politically correct. So they're politically correct.
Well, you know, when there is good news, I think we can say it. But don't want to jinx it. maybe, but no, I don't think we actually said that.
Yeah, but it affects how we proceed because a lot of times, even especially in when that was mentioned and you're not really seeing as many cases, persons were not swabbing as much.
Yes, you have fatigue.
Right.
Yeah, you have fatigue of the health staff. And so if it's downgraded, that will help to give them some amount of relief, even in terms of the frequency of reporting. Not to say you wouldn't continue to monitor. Have to continue to monitor, because then how will we know if cases start to pick up again? But to kind of say, all right, you can relax now, you can move to sampling 1 in 10, not every case. Yeah, those are things that I think really need to be done. It's not a perfect system. All right. We have to continue to maintain surveillance activities and monitor the disease or the syndrome over time. To say that it's a team effort, usually have a team leader with strong epidemiologic skills, and can have the medical officer of health, who is a team leader in the parish, or an epidemiologist, public health nurse, public health inspectors, or environmental health officers too. They help to conduct site investigations, collect data, collect samples, water samples, food samples, and so on, that are tested to know the etiologic agent. The lab support guide sample collection, and that needs to be clear from the get-go what sample we expect to come in. So for influenza and respiratory illnesses, we expect a nasopharyngeal swab. For dengue, we need a blood sample in a red top tube, so it's a clotted sample. For leptospirosis, we're going to need it in the purple top, so you have to have some anticoagulant there. So it has to be clear so that people send the right sample so they're not rejected. And
that is not as clear as we think, because we realize when they get the sample, staff able to around. This one's already too fast. So I find that information. Yes, you probably said we should know that, but I don't think it in the field.
Yeah, I think those things have to be clear from the beginning, so that because that's the time when you're trying to figure out what is causing it. So if we have appropriate samples coming in, then we can pick up earlier what the causative agent is. We need to have designated spokesperson to communicate with the media so that accurate, clear information goes out, and everybody needs to be saying the same thing. You can have some here advocating for vaccine and some over here say no. You can have the parish saying, oh, we have 100 cases, and then ministry say, oh, you have 50, you know, that kind of thing. It should be clear, it should be accurate, and it should be consistent. We need surveillance officers, statisticians to do data analysis and generate the information that is needed to inform the actions. So we look at the, I had one line for the attack rate, and now we've gone into 2 lines. Okay, I'll explain. The attack rate, the number of new cases of a disease during a specified time period. Number of new cases divided by the total population at risk. So those exposed, that's the total, and those who get the disease, that would be the numerator. So number of new cases of a disease during a particular time period, that's the numerator. So can fix the line. What's underlined is the numerator then.
Right.
Yeah. And then what's not underlined is the denominator. So it is an incidence rate, but we use it during an outbreak and call it an attack rate. The other definition that you need to know, and the same thing here, is that what's underlined is the numerator, right? And the case fatality ratio or rate, most people use rate, but I've seen case fatality ratio. It's the proportion of people diagnosed with a specific disease who die from that disease. So out of all the cases, what proportion dies? And it's an indicator of the severity of a disease. And we would usually report on the case fatality ratio for COVID. And we look at the number of deaths due to COVID divided by number of cases, and it's given as a percentage. So we multiply by 100. And then you can look at it in different age groups. And we noted in COVID that the case fatality rate in the elderly was higher than in the younger population. We went through this 2 days ago. We look at the case definition, a standardized set of criteria that we're going to use in determining who we're going to call a case of a disease that we're investigating. And it should include information related to the person, place, and time, include the symptoms, we clear as to what we're using as suspected, probable, or confirmed, and be clear if we're going to use clinical symptoms or laboratory, or we're going to use epidemiological linkage. Because if we can say, if you are in some way in contact or epidemiologically linked to a confirmed case, then you're more likely to be a case. So we may bump you up if you're having symptoms to probable. So the case definition needs to be clearly defined. And this is my shameless plug for the class 1.
All right. Excuse me, Miss Plunkett here.
Yes, go ahead.
All right. The last 3 slides and plus another one that you were speaking about, the monthly mean. All right. Was for this presentation, it was posted on our site for us to view it and be able to print it as well. So these 4 slides, I'm not seeing it on my presentation that I printed.
Thanks for that.
Yeah, I haven't updated I haven't put the updated version on the site yet. I'll do that now.
Okay.
I'll sort them out.
Thank
So
you.
give it like 5 minutes and read it.
Yeah, I sent
All right.
one earlier in the week, and then yesterday I added some slides and I just sent it last night. Yeah. So we have case definitions for all the class 1 notifiable conditions and the class 1 poster that's in all the public health facilities, and some private facilities have the class 1 poster that's displayed. It was updated within the last 2 years to include conditions that weren't class 1 up to a few years ago. So it now includes COVID-19, Zika, chickpea, Mpox, and updated case definitions are there, along with what specimen to collect. So it's there on the class 1 poster. If you're in the public health facility, but they're also disseminated to the MAJ to give to doctors that have private practice. So this is available with the case definition. So as we're on case definition, I just put this in, and to remind about the Public Health Act with the class 1 notifiable diseases require that if they're suspected, they're to be reported within 24 hours to the public health, the parish health department, or the national surveillance unit. And as I said, in the act, you will have the diseases that were designated as class 1 then, but of course, there'll be new ones added over time. So to the case definition now, we decide how we're going to categorize the cases. So if they went to the banquet, and the banquet would be the example that we're using, persons went to the banquet and then start having abdominal cramps and diarrhea. Then we may say, okay, this is a suspected case, they're linked to that event, and they're having symptoms, this is a suspected case. Probable is a bit higher, so you're more sure that this is a case. So it could be a case that has more of the clinical features. So a case with, say, bloody diarrhea. If we're talking about salmonella, we have bloody diarrhea, you're more sure that this is a case since they're linked to that banquet or luncheon. And a confirmed case now, they have isolated salmonella from stool culture, then that would be a confirmed case. So the point is, from the class 1 poster, if we're in an outbreak also, we have clearly defined criteria or case definition to see what are we going to call a suspected case and probable case. And it is in that order based on how sure we are that this is a case of a specific disease. And it could be lab, it could be clinical alone, you know. All right, and we have standardized forms, the case investigation form that will have demographic information. We have contact information. If we need more data, we contact them. We have risk factors. So were they exposed to water? Are they farmer? The occupation? Were they in the water? Did they drink or eat anything that could be contaminated with urine from specific animals? Risk factor information is there because that helps you to make the determination how sure you are that this is a case. It's a sample case investigation form for Mpox, still have monkeypox on it, but Mpox, formerly known as monkeypox, just to give you an idea of the things that you look for. It would be specific to the disease. The symptoms there would be specific to the disease. So for Mpox, of course, it's going to ask about the rash. But for another condition like COVID-19, you wouldn't see, say, rash on the form as a symptom. You see fever, you see cough, shortness of breath, and so on. So ask about the symptoms, the comorbidities, contact with the confirmed case, travel history, vaccination history, important for COVID, but for measles and rubella, vaccination history very important. If they were recently vaccinated, you could get a positive test because of the recent vaccination. So if you don't put it that they were recently vaccinated, the date of the vaccination, and the person have fever and rash, test them for measles, it's positive, can cause panic. Oh, do we have a case? But then when you check back, you're recently vaccinated. So just to say that vaccination history is important. We're not going to watch this video. There wasn't the plan to watch it. It's quite long, but if you're interested in looking at the Ebola outbreak and the challenges relating to the management of outbreaks, and you can look at videos of COVID-19 outbreak and challenges related to management of these outbreaks. But remember the 10 steps, remember outbreak management as well. So really that's outbreak management, just a little know on the international health regulations. Just want to pause if there are any questions. Drink some water. All right. So the international health regulations of 2005 were adopted at the 58th World Health Assembly in May 2005, but came into effect in 2007. This is a set of legally binding global agreements with procedures to protect public health. And 196 countries have signed on to it. The scope has broadened beyond what existed before, because there was a previous iteration of the international health regulations to include public health emergencies of international concern. So these are events that that there's a possibility that it's going to affect travel and trade, it's going to affect several countries with wider implications for morbidity, mortality, for the economy and the response. And it may be beyond what the country can manage in terms of containment. Those would be public health emergency of international concern, and it requires that the World Health, the advisory committee at WHO look at all the factors surrounding the incident and making that determination, then advising the Director General, and then upon advice, they'll make the determination, that's the WHO, if they're going to declare it public health emergency of international concern, and recent ones would be Mpox, COVID-19, both declared public health emergencies of international concern. So that's 2005 and that's 1969. So the 1969 International Health Regulation, I put it here, and it's not in the previous slide set. So it was updated because, you get asked all the time, what are the reportable diseases under the international health regulations? To say that in 2005, the scope was broadened to include anything that could constitute a public health emergency of international concern. And the idea is that they want to prevent and protect and control diseases or health events so that they won't have international spread and there won't be any unnecessary interference with international travel and trade. So originally they had 6 reportable diseases: cholera, plague, yellow fever, smallpox, relapsing fever, and typhus. Those were reportable diseases. Now, smallpox has been eradicated. Don't know what the rationale is for the other 2, but the reportable diseases now are cholera, plague, and yellow fever. If it's seen, then we have the obligation to report to WHO under the international health regulations. But if there's any outbreak or any case here that we think, I don't want to call any name about any disease, I want to not call it, that we think could have international spread or interfere with travel or trade or affect other countries, then we still have the obligation to report. And there is a IHR focal point here that would communicate that to WHO, and the IHR focal points communicate in different countries, communicate with each other. For example, if there was a case of Legionnaire's disease who visited Jamaica and then went back to the country and was diagnosed, then they inform us so that we can investigate. All right, that's it, projecting. So it's integrated into WHO's ongoing activities. There should be transparent flow of public health information with full respect for human dignity and civil liberties, and importantly, respect the sovereignty of each of the member states. So it is voluntary reporting, just like we have the passive surveillance system, where we have the class 1 conditions and the healthcare worker reports when they see a case. Now, if a country sees something and it fits the criteria and there are guidelines and algorithms that the IHR prescribes that you go through to see, does it meet the criteria for reporting? If you go through and it meets the criteria, then you're obligated to report. But just want to emphasize, it's voluntary reporting because the countries are sovereign. Okay. All right. So, I'd say summary, that means we're coming to the end. So, any questions before I summarize?
Especially in 10 steps.
Yes.
If you give me tips.
Tips to memorize them. Like a mnemonic. Swap them off. There's the 10 steps. I mean, from my time, they give the scenario so it can come. When you say 10 steps outbreak investigation, you start writing down 1 or 2 that you remember, you know, and then it comes back. If you studied it. If you studied it, it will come back.
Do you know how we're graded for this course?
Huh?
Do you know how we're graded for this course?
I don't know. I don't know how the grading goes. It's 2. It's It's EP2?
Yeah.
Oh, okay, I think, is EP2 or 3 have the essay? It's 3?
I don't know.
I don't remember.
I'm gonna put it in one.
All right, I don't want to mislead you. I don't know how it is graded, but maybe the course outline will give that. Okay. So we went through important definitions, including an outbreak, cases occurring clearly in excess of what would normally be expected. We talk about clusters of cases, aggregation of cases in a localized, in a specific area over a point in time, say in an infirmary, in a workplace, and so on, and a pandemic. That's a larger outbreak spreading over a wider area, several countries or continents. And the types of epidemic, the common source or propagated, and for common source, point source, intermittent, and continuous. And the definitions look at the epidemic curve that shows the number of cases over time. And literally that's how the chart looks, the number of cases on the vertical axis and time on the horizontal axis, whether you use the epidemiological week or epi week or use the month. You can have years as well. You have data of a longer period, and so we define the epi week, a standardized way of numbering the weeks in a year. And we say the first epi week starts the first week of January, if the first week of January has at least 4 days in it, and it's always starts on a Sunday, ends on a Saturday. So you may have 53 epi weeks in the year, and you may have some days from January kind of tagged on to the previous year, or some days from the December going into the first epi week of the year that we're looking at. Looking at the epidemic curve, we saw how the epidemic curves for the different patterns or types of epidemic would appear. And I tried to give some real life examples and just emphasize that maybe for your exam, I don't know, they will give perfect examples, or in the course, sometimes you get perfect examples, but in real life, you just have to apply what you learn from what's perfect to real life situation. And it may not look like how it appears in the textbook, but you have to try and figure it out. Talk about the goals of an outbreak investigation to define the cases, manage the cases that are infected, how we manage the cases, how we track them over time. We break the chains of transmission and prevent the susceptible cases from getting infected. And we talked about the 10 steps of an outbreak investigation. I want to just put up that slide. Well, I'll let that be the last thing. We go back to it. So it will be fresh in your mind. Talk about management of an outbreak and how important communication is to send consistent messages, ensure that there is information on how the public, how people can protect themselves, so that you have personal responsibility, not just the health system making all the interventions, but tell people how they can protect themselves, because people are responsible and they don't want to get ill. Well, many are. So they will implement measures once you get the buy-in. And spoke about the management team on the parish level, how you can have a medical officer, health, epidemiologists, public health
Phrase in
nurses,
English.
public health inspectors. Go ahead. Saying something, Miss Doctor? No, it's not so. All right, and
From a long time.
Anyway, okay, all right.
Simone, the mic is open. Well, it's closed now.
what's left are some references. So we're going to go back to the slide with 10 steps of the outbreak investigation. So it'll be the last thing
Yes, yes, please.
in
I
your
was
head.
about to ask. Thank you.
The last thing in your head. CBM. You confirm. All right, we're getting a mnemonic coming out. That's it. Almost like we have platform in there, but without
Is that English?
the L. Huh?
No, the letter.
No, I was asking if the mnemonic is English.
Well, she started with CVM.
Yeah.
I don't know. That's where we're at.
Red faith plan.
Roof. What? I don't know. But you confirm that the outbreak exists by comparing to previously available data, because we have to look at the baseline, because we have to say it's in excess of what we expect. So that is how we confirm. We look at previous data, look at what we have now, and that's how we confirm. And then we verify the diagnosis, usually looking at the clinical picture, but also lab diagnosis is important to identify the causative agent, because that has implications for what you're going to do for the control mechanisms. All right. Make a quick assessment of the cases. Are we having more males than females? Is the elderly more affected than the young? Is it children that are getting infected? Is it persons who are not immunized, persons in a particular area? All right, so relate the cases in time too. Is there epidemiological linkage between the cases, so you know they were in contact with others, or they were exposed to a particular at a particular event, whether it's the food or we had the example of nuclear accident, and you formulate a hypothesis to see what we think is really causing it. Was it from an event? Is it because of the heavy rains? That kind of thing, because that will guide how you're going to go about the rest of this detailed epidemiologic investigation, looking at the environment, looking at the people, looking at your how to prevent the disease, you know, looking at were they wearing PPEs, you know, is that why they were exposed, that kind of thing. We have to analyze the data, and one of the key tools is the epidemic curve, to look at how the outbreak is progressing. Is it on the upswing or the downstroke? Is it waning now? And of course, the shape of it can help us to to make a determination as to the source or the pattern, the type of epidemic that we're having. And we conclude. We put control measures in operation, whether it's vaccination, we're going to do fogging or vector control, or if it's some contaminated pump, we're going to remove the source of it. For leptospirosis, do we need solid waste management to NSWMA to clean up that kind of thing? And of course, to emphasize wearing of protective clothing, whether water boots, gloves, that kind of thing, so they themselves don't get the disease. And we write a report, and the emphasis is that it's not necessary. These are, yes, called steps, but different things can be happening at the same time, because if you know that it's dengue that's causing it, you're not going to wait until you do all your analysis and complete your epidemiologic investigation before you start putting control measures in place. Once you have an idea, you start putting measures in place. And reporting, as we know, sometimes daily is not really at the end of it that you write the report. So to say, several activities can be happening at once. We have the mnemonic.
CVM rated former prime ministers and found poor work.
All right. You have to talk loud to everybody. All right, go again.
CVM rated former prime ministers and found poor work.
Oh dear. Oh dear. Wow, I think we can remember that one. CVM rated former prime ministers and found poor work. We're gonna remember that one. All right, everybody get that? CVM rated former prime ministers and found poor work.
I will try.
All right.
I have a question as it relates to this current outbreak. So you mentioned, like for example, the lepto emphasizing PPE, the water, boots, and so forth. If we're noticing geographically, I don't know if the peaks are like predominantly in the west or we have it scattered over different parishes. But if it was like concentrated down there, I'm not really hearing, maybe it's not me, but it's not publicized. I'm not really hearing like from Ministry of Health side or Social Security or any one of those agencies really providing water boots or PPEs or gloves to the persons who are out there helping, given the situation that they would have lost something. Maybe something I haven't heard about it.
I've heard about it. I'm not sure how widespread it was, or if it was a private entity. It was on the radio, and they spoke about going down to distribute water boots and so on. So it's vague. And I think it was a private entity, but I don't know. I don't remember the name of it, but they spoke about going down to distribute water boots and so on. I don't know to what extent any of it gets to those at highest risk, but yes, the cases were scattered, but also more cases in the western parishes, the parishes that were most affected, St. James, Westmoreland, St. Elizabeth, but we do have cases further east, St. Catherine, yeah.
It's just something I
St.
thought of,
Anne.
as I'm saying, this is happening. Yes, I'm seeing the Instagram posts and on other social media to, show picture to say, protect yourself and, trying all of those good things. I'm saying what you said, don't have them things. And it can't really, they're a vulnerable population now, so we can't really expect it to go buy it. Maybe the place where they would usually buy from is no more. So, yes, you're saying it, yes, in risk communication, putting out the information. I mean, I know it's not perfect, but I just think, logically.
Okay, I'm going to take that as a comment and not a question. I take your point. Yeah. Great. And you can go back to that YouTube video when you're reviewing to get the summary as well. But remember, I didn't give all the 10 steps, so remember the 10 steps. CVM rated former prime ministers and found poor work.
Thank you very much. I think I've already secured that.
What's your vote? The third, I feel you want to say poor.
No, I said it was excellent. Whoever came up with it, that's amazing. I think it was Jody. Was it?
Yes, Jody, we're speaking of the poor work.
Okay.
Very nice.
Say what it is again.
In those areas.
CVM created former prime ministers and forward.
Not hearing clearly. Come up closer.
We'll put it in the group, but it's all.
CVM rated former prime ministers and found poor work.
All right, nobody go for them, none of Vanetta. Just leave it there, so. Just leave it there.
It's in the group, Vanetta.
Just make sure you scribble this on the side of your paper and okay, right? And don't submit that part of it. if it
Excellent.
All right.
It's just a pity the current one not in it too.
Current one.
I don't have any comment. I'm going to take that as a comment.
Yes, Doctor.
It's not easy to continue. It's not easy to manage any outbreak. But the steps remain the same regardless of the outbreak.
Yes, but as I say, they don't necessarily flow in that order,
So I guess what determines how effectively managed is like the resources that are available at the time. As I say, if the lab is equipped with the reagents to test locally versus sending to
and waiting.
The PPEs, all of the stuff, wash away, a lot of that.
All right. So we take a break and come back. No, we're finished.
What's the next topic?
No, we're finished.
Oh,
Bless you.
okay.
I was joking.
Wait, hold on, Doc. What's the joke? The joke is that we're finished, or the joke is that we're taking a break?
Joke is that we're taking a break.
So we're finished.
Yes. All right.
Okay, thank you.
Okay, thanks for your attention and all the best.
I'm sure you mentioned that the first region.
Yeah, Ministry of Health, the National Surveillance Unit. And Like I said, I updated the presentation and sent it, so Sebastian will get the.
Maybe we got the updated one, so just the president.
Okay, so what's printed was the updated version.
Right.
What will be,
But he said he already put the updated one online, so then let's need to check that.
okay, so the updated one is online already.
Thank you.
Thank you, and all the best.
The traffic is crazy. Oh, thank you. Yes, it was. Yeah. No, maternity. It was the maternal mortality rates and days and stuff. That was kind of. Everybody does family health. Yeah. That was something. Everybody have a comment? Just like you are. Even if other things that were to say. So. Yeah. Okay. Oh, okay, what the hell is it? Check it out, crazy. Yes. So, I was in January. I remember saying this in my tribunal, but you can't say anything.
All right.
Christmas. Christmas. Christmas over on the third. I'm still at the same day.